Hello everyone, let's go to SLE. Let's talk about a sample long case of SLE today. So what I'm going to do, I'm going to discuss the long case that I prepared, and I'll stop at some points and I'll try to explain whatever I'm saying. Okay, so quick case, very important, very high yield SLE, systemic lupus erythematosus. So without further ado, let's begin our case. Mrs. Mrs. Yasmin Begum, a 37-year-old woman hailing from Narayanganj, presented with weakness of all four limbs for the last 3 months. All four limbs. According to the statement of the patient, she was reasonably well 3 months back. Then she developed weakness of all four limbs, which was gradually progressive and more marked in proximally, evident by difficulty in standing from sitting position, difficulty in climbing stairs, and raising her hands above the head level. I don't have proximal myopathy because I can raise my hand. This was not associated with in pain, so not myositis, tingling, numbness, and paresthesia. No pain, tingling, numbness, and paresthesia, so not neuropathy. And no diurnal variation with drooping of eyelids, so not myasthenia. But she has been taking steroid for the last 1 year. For this weakness, she consulted a local physician without any significant symptomatic improvement. For better evaluation and management, she was referred to BSMMU. 1.5 years back, she was diagnosed with a case of SLE on the basis of symmetrical inflammatory polyarthritis involving small joints of both hands, both elbows, and both ankle joints. Several episodes of oral ulceration and alopecia. I think I am having one. Then she was prescribed hydroxychloroquine 300 mg at night and tablet prednisolone 40 mg at morning, with which her symptoms, which are the joint pain, the oral ulcer, and the alopecia, partially improved. Her symptoms partially improved after taking those drugs. For the last 1 year, her disease goes on multiple relapsing and remitting courses. For the last 6 months, she is gaining her weight, and she noticed weakness in both the upper and lower limbs. She had no hypertension or diabetes mellitus. During her course of illness, she gave no history of photosensitive skin rashes or sequential color change of fingers on exposure to cold, no seizure or unconsciousness, no red eyes, no exertional shortness of breath or chest pain, no orthopnea or paroxysmal nocturnal dyspnea, no postprandial abdominal pain. There is no history of thickening or tightening of skin, no history of reduction of urine volume with body swelling or back pain. So here, those need some explanation. So no history of photosensitive skin rash. This is a common finding in SLE, but she doesn't have that. No history of sequential color change of fingers on exposure to cold. We're excluding Raynaud. No seizure or unconsciousness, not CNS, lupus, but does not involve any nervous system structure. No red eyes, so not uveitis or not conjunctivitis. No involvement of the heart, such as myocarditis or pericardial effusion, because patient does not have any cardiac symptom, which are exertional shortness of breath, chest pain, orthopnea, or PND. She doesn't have those. It's very good. No postprandial abdominal pain, so there is no vasculitis. There is no mesenteric vasculitis leading to mesenteric ischemia, but she doesn't have that. Very good. Thickening and tightening of skin, not SLE, because oftentimes you can have an overlap, SLE SS overlap, but this is not SLE SS overlap because she does not have any tightening or thickening of skin. Very good. Then reduction of urine volume, that means lupus nephritis. She does not have this because there is no reduction of urine volume with body swelling or back pain. So she may have lupus nephritis, but she does not have the severe version, does not have nephrotic syndrome, or does not have severe glomerulonephritis. Might have the early stages, stage 1, stage 2, grade 1, grade 2, but it's not like grade 4 or 5. So back pain is a common symptom that we mention in all cases of patients with autoimmune diseases. May have back pain, but may not have back pain. Now, other history. She had no past illness like hypothyroidism or any other autoimmune disease. SLE is an autoimmune disease which may occur along with other autoimmune diseases. So we are trying to say that she does not have any other autoimmune diseases. There is no history of such illness in her family. That is a family history. She is married for 4 years. She has one son, but no history of adverse pregnancy outcome. So not APL or antiphospholipid syndrome. She uses no contraception. Before starting the steroid, she was vaccinated against hepatitis B, influenza, and pneumococcus. She is also vaccinated against COVID-19. She felt occasional apathy, but she never felt any suicidal tendency. This is all about my history. Then, on general examination, she looks ill, obviously, comfortable at supine position. There is non-scarring alopecia, mildly anemic, not icteric, and there is a skin rash in a butterfly distribution. Skin rash in a butterfly distribution. There is an IV cannula in situ, and bedside urine, very important. Bedside urine for protein is positive. She does have lupus nephritis, maybe the early stages, but she does have lupus nephritis. Bedside urine for protein is positive. Other general examination findings, including vitals, are within normal limits. On musculoskeletal examination, she has weakness in both upper and lower limbs, evident by muscle power MRSA grade 4, involving especially the proximal group of muscles. Hand examination reveals tenderness in the carpal joint, in the metacarpal phalangeal joint. Those are the metacarpal phalangeal joint, and the PIP, proximal interphalangeal joint. Tenderness in the carpal, in the metacarpal, and the proximal interphalangeal joints. Hand examinations also reveal slight restriction of both active and passive movements, but there is no sensory impairment. On neurological examination, on fundoscopy, you are doing a fundoscopy, it reveals cortinal spots in both eye at 8 o'clock position in the right eye and 7 o'clock position in the left eye. So if this is my right eye, my 8 o'clock position would be probably here maybe. Other systemic examination findings are within normal limits. This is all about my history and examination. So my probable diagnosis is SLE with steroid-induced myopathy. My differential diagnosis is SLE with myositis. Okay, so very simple case. Very simple case. This is my sample long case of SLE. So let's recap. Let's go through the case again and review as a whole overall. Mrs. Y, 37-year-old woman from Narayanganj, presented with weakness of all 4 limbs for the last 3 months. According to the statement of the patient, she was reasonably well 3 months back. Then she developed weakness of all 4 limbs, which was gradually progressive, and more marked proximally, evident by difficulty in standing from sitting position, difficulty in climbing stairs, and raising her hands above the head level. This was not associated with any pain, tingling, numbness, and paresthesia, and there's no diurnal variation with drooping of eyelids. But she has been taking steroid for the last 1 year. For this weakness, she consulted a local physician without any significant symptomatic improvement. For better evaluation and management, she was referred to BSMMU. 1.5 years back, she was diagnosed as a case of SLE on the basis of symmetrical inflammatory polyarthritis involving small joints of both hands, both elbows, and both ankle joints. Several episodes of oral ulcer and alopecia. Then she was prescribed hydroxychloroquine 300 mg at night and tablet prednisolone 40 mg at morning, with which her symptoms partially improved. For the last 1 year, her disease goes on multiple relapsing and remitting courses. For the last 6 months, she is gaining her weight and she noticed weakness in both the upper and lower limbs. But this is more severe for the last 3 months. She had no history of hypertension and diabetes. During her course of illness, she gave no history of photosensitive skin rash I mean, although she didn't give any history of rash, we found later that she does have rash. Oh my god. Sequential color changes of finger on exposure to cold. No seizure or unconsciousness, no red eyes, no exertional short of breath, chest pain, orthopnea or PND, no postprandial abdominal pain, thickening and tightening of skin, reduction in urine volume with body swelling or back pain. She has no past illness like hypothyroidism or any other autoimmune illness. There is no history of such illness in her family. Very good. She is married for 4 years, but she has one son, but no history of adverse pregnancy outcomes. Her menstruation is regular and she uses no contraception. Before starting the steroid, she was vaccinated against hepatitis B, influenza, and pneumococcus. She is also vaccinated against COVID-19. She felt occasional apathy, but she never felt any suicidal tendency. This is all about my history. On general examination, she looks ill, comfortable. There is non-scarring alopecia, mild anemia, no jaundice, and there is skin rash along a butterfly distribution, IV cannula and C2, and most importantly, bedside urine for protein is positive. Other general examination findings, including vitals, are within normal limits. On musculoskeletal system examination, she has weakness in both upper and lower limbs, evident by muscle power MRC grade 4 involving the proximal group of muscles. Hand examination reveals tenderness in in her carpal joints, metacarpophalangeal joints, and the proximal interphalangeal joints. And there is some slight restriction of both active and passive movements. There is no sensory impairment. On neurologic exam, fundoscopy reveals cotton wool spots in both eye at 8 o'clock position in right eye and 7 o'clock position in left eye. Other systemic examination findings are within normal limit. This is all about my history and examination. So my possible diagnosis is systemic lupus erythematosus with steroid-induced myopathy, systemic lupus erythematosus with myositis. That's all. That's a classic case of systemic lupus erythematosus that you are going to get in your exam. So review, repeat, and practice. Okay? Don't forget to like and subscribe and click the bell icon.